The broadcast is now starting. All attendees are in listen-only mode.
All right, welcome everyone to the November edition of the Interprofessional Clinical Trauma Webinar Series brought to you by Nova Scotia Health Trauma Program. My name is Bree. I've recently started as the Nursing Education Lead for the Provincial Trauma Program, and I'll be your moderator today. We are lucky today to have Dr. Sean Christie presenting. He is a neurosurgeon at the QE2. He's one of our trauma team leaders, a professor at Dal, and most recently made the news, including the cover of the QE2 Times, for the first neurosurgeon in Canada to utilize a surgical robot for neurosurgery. The title of today's webinar is Cranial Trauma in the Golden Hour. And just a reminder, everyone is muted except for the presenter. If you have any questions or comments or anything you want to say, just enter them in the chat box. You'll see it in the, I think, the bottom right of your screen. And that's enough of me talking. I'll let you go ahead, Sean.
Okay, thanks very much, Bree. Can you hear me okay?
Yeah, everything seems to be great.
Okay, good. Well, thanks for that introduction. I guess in about another 40 or 50 minutes, people will decide whether we're lucky or not. But I guess the only thing just to clarify is it wasn't the first neurosurgical robotic, it was the first spinal robotic surgery, but it's still pretty exciting times, the advancements that are being made and the opportunities that we have here in Nova Scotia Health. So for today, what we thought we'd talk about is a little bit about cranial trauma and really focus on the very early management. I'm not going to spend a lot of time on what we as neurosurgeons will do. I think I've tried to outline the things that need to be done or the opportunities that we have to have an impact before people get to a neurosurgical center. So hopefully that'll be all right with everyone. And if we have any questions about the other stuff, we can certainly do that towards the end. So theoretically, my slides are advancing. I don't have any disclosures related to this talk. I do some work and have some disclosures, but it's related to spine and spinal cord injury and robotics, but not to cranial trauma. So the objectives for today that were circulated is to review the initial assessment of trauma patients that are suspected to have cranial injuries, to develop a bit of an idea of how to assess the need for radiological investigation, and to determine who needs to come to Halifax or at least get a consultation. And lastly, and I think this will hopefully be the most helpful, is what early interventions can we look at that can be beneficial for the patients. So to do this, I will perhaps bore you a bit with some epidemiology and some anatomy and physiology, but I promise I'll try to keep it short. We'll emphasize a couple of pearls on the exam and really a focused trauma cranial exam. I'm not going to get into great detail of the nuances of things, but just what we need to do in the first hour. And then we'll look at some imaging and different classification approaches that we can do for people that have cranial trauma. And then we'll talk a little bit about the management, as I mentioned. So in the end, we'll have some time for questions, and hopefully that'll be fruitful for people. I also don't mind if people want to ask questions throughout. If they do, Bree, can you just let me know, because I can't really see the chat box right now.
No problem. Did you want me to stop you during your presentation to ask those questions?
Whatever you want to do is good with me. So in terms of epidemiology, cranial trauma is fairly common. If you look at North America, there's over 1 million visits a year. The majority are minor head injuries, and the minority are severe head injuries. And the definitions here, as you see as we'll go through this, will vary a little bit. Just one point there, Bree, you can see my pointer.
Yes, I can.
Okay, just in case I point things out later on. And the other thing I just want to mention is, for the purposes of this talk, we're not going to get into minor head injuries and management of concussion, because I think that's a whole talk in of itself. And really trying to go through what I'm going through today is quite a bit to bite off in 45 minutes. So we'll focus primarily on severe head injury. And with these million people, the costs are quite substantial. And these are treatment costs. It doesn't really look at long-term costs of survivors and needs that people may have. And it's no surprise that traumatic brain injury is higher among males. That number is coming down a little bit, but it's still quite disproportionately a male pathology. Falls are becoming more common, and there'll be some differences in the demographics or the epidemiology depending on where you live. So I thought that I'd pull out a little bit of data that's local, just so that people can get a flavor for what happens in Nova Scotia. So Doctors Green and Clark and Nilufar Qureshi put a paper together a few years, well, just 2 years back, year and a half, that looked at the epidemiology over 15 years in Nova Scotia. And we see a steady, slow increase in the number of major head injuries within our province. And there does seem to be a disproportionate rise in the number of major traumas in older people, so people over 65. And this is beyond the increase in population that we see. So the top line is the increase in population, and the lower line that has a steeper curve is the increase in trauma. So we're seeing more people in an older age group. And as I mentioned earlier, we're seeing slightly less males than we had seen before. And we're seeing a greater rise in falls. And I think that this is largely related to the change in demographic and what's coming in, but we've also made some headroads with education, some legislations and such, that the incidence of motor vehicle crashes is slightly decreasing. And violent trauma is up and down, but about steady, which is good. So that's the lay of the land in Nova Scotia. Now, if we move to anatomy, and just bear with me a little bit as we kind of go through this. So what is unique about cranial trauma? Well, from an anatomical standpoint, we have a closed box, which is the skull, and within that box contains our brain, and also the blood volume, which will be comprised both of arterial blood as well as venous blood. And then there's also CSF. And it's about an 80-10-10 split between brain, blood, and CSF. Now, in normal physiology, the body can accommodate ranges of blood pressure and maintain a steady flow through a concept called autoregulation. So it's an autonomic dilation and constriction of cerebral vessels that maintains a constant flow. And as you can see on this graph, if you're between 50 and 150 for a map, then you're going to have a consistent blood flow. When you go lower or higher, it starts to deviate. But what's important is that once you've disrupted the brain, or you have a brain injury, then the brain loses, to some extent, either globally or regionally, the ability to autoregulate. And then the blood flow is more directly related to the map, and that's the dotted line here. So this is one of the reasons that we'll talk about this again later on, is why we spend a lot of time managing CNS trauma, driving pressure to a map, because we recognize that the autoregulation mechanisms are not working. But the idea here is that when they are working, with variations in blood pressure and variations of what's going on inside the closed box, we will maintain some perfusion, an adequate perfusion of the brain, and maintain neurological function. So then with trauma, obviously that can change. So if you have a hematoma, and that hematoma takes up space, then it has to displace something. It's not going to typically displace the brain. The brain tries not to displace the arterial flow because you need to have that, but you can see there's a little bit less perfusion in the brain here than there is in this slide. But what tends to happen is there's a shunting of CSF and venous blood initially to maintain the pressure within the box. And as this progresses, and the hematoma, for instance, gets larger, then more CSF and more venous blood is displaced. But this increased pressure does affect the ability of the arterial blood to provide adequate perfusion to the brain. And at some point, the ability to compensate for rising intracranial pressure is lost. And we get what you may call a point of decompensation. And many of you may remember this or have heard of this as the Monroe-Kelly doctrine. And there's a Scottish physiologist that described this. But the bottom line is, as you go along with those compensatory mechanisms, the brain can maintain a good perfusion pressure. But at some point, you lose that ability. You lose the compliance of the brain tissue, and you lose the reserve that you have with the venous and CSF. And then after that, small changes, such as 1 cc of blood, can deliver massive changes in your intracranial pressure. And then that relates back to your cerebral perfusion pressure and ultimately your blood flow through these equations. So your mean arterial pressure minus your intracranial pressure is your cerebral perfusion pressure. What we're really interested in is the cerebral blood flow, but that's not easy to measure. So we use the cerebral perfusion pressure as a surrogate. But if you look at this graph, you can conceptualize that if autoregulation is gone and your perfusion's reliant on your map and your intracranial pressure are going to dictate how much blood can get into the box. And if we don't get enough blood into the box, then we don't hit the thresholds for neuronal survival. And once we drop below 20 or 25 cc's per 100 grams per minute, you start to have dysfunction of neurons. And once we drop below 15 or 20, and then if it's prolonged any length of time, then you start to get death of neurons. And so this is what we're trying to prevent. And you can see it again conceptually. So what happens when we pass this? Well, we're going to get increasing pressure. That feeds back to more neuronal loss, less blood flow, and it becomes a cycle. And when you get that cycle, then you get more swelling, and then that leads to what we don't want to see, and called herniation syndromes, which are movement of the brain from where it's supposed to be to another compartment of the brain, in a nutshell. So you can herniate out through an open skull fracture. You can have subfalcine herniation, you can have downward herniation or upward herniation. But the two people hear about the most would be tonsillar herniation, when the bottom part of the cerebellum comes down through the foramen magnum, or uncal herniation, where the medial part of the temporal lobe pushes in against the brainstem. And just depicted a slightly different way, you see tonsils coming down from either a posterior fossa clot or increased pressure in the supratentorial compartment. And this downward pressure will cause compression and dysfunction of the medulla, which, as you know, is vital for homeostasis activity. Uncal herniation, I think this picture just outlines nicely the findings that you see. And this is probably one of the, the classic situation that people are frequently asked. So this view here is looking from the front and the right towards the back. So this is the pons, and this is the basilar artery, and this would be the right third nerve or oculomotor nerve, and this would be the left third nerve. And then this here is the medial part of the temporal lobe, or the uncus. So if you have an expanding hematoma that pushes that in, it's going to push up against this third nerve. And as you know, the third nerve, the fibers around the periphery of the third nerve mediate pupillary constriction. So if those fibers are not working, your pupil will dilate. And if the pressure is great enough on the midbrain, these are the descending motor fibers that are going to come down from the cortex through the internal capsule, through the cerebral peduncles, and cross over to the other side. So with a herniation here, you're going to have a dilated pupil on the same side, and you're going to have weakness on the other side because of these fibers that get pinched here before they cross over. And that's the classic triad that people talk about: an ipsilateral blown pupil, contralateral hemiparesis, and decreased level of consciousness. Now, there's some different nuances and different things can happen, but this would be the common thing. So taking kind of that clinical scenario and then translating or shifting into our assessment, despite the hierarchical importance of the brain, let's say, it really is not number one, number two, or number three when it comes to trauma, because if you can't get oxygenated blood to your brain, either because you're not ventilating well or you're hypotensive, then you're fighting a losing battle. So ABCs are always the priority. As you know from HLS, an ample history is important. Specific to cranial trauma, we like to know if there's any drugs or alcohol on board, because that impacts your assessment. We want to know if there's a history of seizures, either remote or related to the event. And another common question would be whether there's any loss of consciousness or antero-retrograde amnesia. And in severe TBI, we may not get answers to these questions, or maybe surrogates that have to give answers. In milder head injuries, you may be able to talk to patients and get some of these, get some of this information. And then, of course, D. So, for your neurological assessment, the most straightforward, most bang for your buck is a good Glasgow Coma score, recognizing whether there's lateralizing signs or not, and what are the pupillary responses. And here's just an example of a dilated left pupil, for instance, from that diagram that I just showed you. So the GCS, I think, there's a number of caveats, and you could probably do a whole talk just on the Glasgow Coma score. It's certainly been adopted and used beyond what it was originally devised for. It was originally devised to predict outcome from head injury, but not in the early hours. It's more of a delay. It was initially more of a delayed evaluation to predict outcome. However, we do use it as a way to communicate findings, communicate the physical condition of patients from a neurological standpoint, and we also use it internally or along the same evaluator to look for any changes. So it does have some merit, but it does have some cautions. And I'll just take a couple of minutes on this because I suspect everybody's familiar with it, but just a couple of nuances. So there's three categories: eye opening, and you can see there, that's a score of 4. So if your eyes are open spontaneously, you get 4. Verbal response, you can be oriented, confused, you can make words, but they're not appropriate to the context, or you can just make sounds. So there's 5 potential points there. And then the motor response is sometimes what some people get a little confused with, but I think most people, when they look at it, it becomes more straightforward. But you can follow commands, you can localize the pain. So localizing the pain in the original pure definition is that a hand crosses midline in two places to remove noxious stimulus. So ideally, and we don't always do it like this, but ideally you stimulate in two different locations in the hand, and your hand will cross midline to try to remove the uncomfortable or noxious stimulus. Withdrawal to pain is not as intentional. It doesn't cross midline, but it still does try to withdraw from pain. And then decorticate and decerebrate posturing. I just threw a couple of pictures here because sometimes this is a little less easy to sort out if you don't see this a lot. So if people tend to have adduction, flexion of the elbow, flexion of the wrists, this is this is a decorticate posturing, which we see with injuries typically above the level of the red nucleus. So the red nucleus is a flexor motor control pathway. And if you lose that inhibition from higher cortical centers, you'll see a pattern like this. Now the red nucleus the rubrospinal tract does not descend all the way to the lower extremities. So you'll see that in both decorticate and decerebrate posturing, the legs are extensor. So don't look at the legs, look at the arms. So flexion, decorticate posturing looks like this, and decerebrate posturing, you're extending the elbows, you're turning the arms out, so you're internally rotating the arm and flexing the wrist. Again, the legs extend because that's the vestibulospinal tract. So to go from decorticate to decerebrate posturing, you've now developed an injury that is between the red nucleus in the midbrain and the vestibular nucleus in the rostral medulla. So we've injured in the pons. So we see as we go through here, you can march down through the neuraxis in terms of where the injury is. So once we have our physical assessment, the question is when to image. And there's a number of different guidelines that are out there. The American College of Emergency Physicians, the Center for Disease Control and Prevention in the US, the National Institute of Health and Care in the UK. There's the Canadian Head CT rule that's from Ottawa. But probably an easy way to remember things, and what we recommend as a group here, is this poster, which everyone that's been in a trauma bay in Nova Scotia hopefully has seen, and if not, we can certainly get you this. And it breaks things down into 3 categories. So pediatric, which again is a talk in of itself, which we're not going to be able to get into today. Mild head injury, which for the purposes of this is a GCS of 13 to 15. And this gives you some idea of when you should order a CT scan, or when we would recommend that you consider ordering a CT scan. And then GCS of 3 to 12. And to make it simple, if your Glasgow Coma score is in that range, then you probably need to have a CT scan. And the question then becomes, do you have a CT scan right away, or do we call the trauma line and or neurosurgery, get you down here and have the CT done here? And as you'll hear over and over again from this talk or other ATLS things, we don't want to delay transport to do imaging. If there's time, then it can provide helpful information. Then in conjunction with the receiving team, we can work that out. But this is a framework that I think is a little more straightforward. It's up in all the trauma rooms, and then we'd suggest to adhere to that. So once we've broken all this down, we've got our GCS, got an idea of when people are going to have to leave and be seen by other higher centers. let's just kind of shift gears a little bit and talk a bit more about head injuries in general and some different ways to classify or think about these. So we just talked about the clinical exam, so we can classify them based on severity. And there may be some little variations if you look at from paper to paper, and even within this presentation, in different aspects, you see that severe has been 9, it's 8. But in general, more times than not, people would say a severe head injury is less than 8. And that's what we're focusing on today. We can talk about whether a trauma is blunt or penetrating. The picture here, where not many people are getting impaled by railway spikes anymore, like Phineas Gage did. But we do see blunt trauma fairly commonly with contact to the head, either external or from a contained car crash or something. We can see penetrating trauma. It can be low velocity, such as nail guns. We've had a couple of these this year. Or it can be higher velocity, such as gunshot wounds. And again, unfortunately, we've seen a couple of those. So that's another way to look at things. And then we can look at how the brain itself is affected by the trauma. So is the injury to the brain focal or diffuse? And we can run through a few of these things quickly, but focal injuries can be things like contusions, where you have bruising, if you will, of the brain. And contusions and intracerebral hemorrhages are on a bit of a spectrum. And they typically happen in locations where the brain comes in contact with the skull. So middle fossa, anterior fossa is another common one, petrous ridge, and these, as you can see, can bloom and change over time. And just another example, these would be one of the more common intracranial findings that we would see. Now, contusions can be coup, so if you get, this is where, for instance, you fall, you get hit here, you can have a subgaleal hematoma, and you can sometimes get a contusion here, or you can get it opposite that in what's called a contre-coup injury. And then, as I mentioned, you can see that these contusions typically evolve over time, with the majority of changes happening in the first 48 hours. So another focal finding would be an epidural hematoma. And I think this is the one that people hear about a lot. This is the talk and die patient, or the patient that has a lucid interval, usually associated with a skull fracture, but not always. When a skull fracture's, sorry, just something popping up on my screen. When a skull fracture occurs, the pathology is usually a laceration of a dural vessel, like the middle meningeal artery. As I mentioned, people can have a lucid interval and then have a decrease in their level of consciousness. And these can occur in a venous setting, such as over a sinus, like I show you here. They can have a mix of acute and clotted blood. So if you see an epidural that, or you see any bleeding, that's a mixture of this hyperdense with dark areas, that may be an indication that there's still some active bleeding that hasn't clotted going on. And you can also see them in the posterior fossa in association with fractures near the sinus. And these are surgical. These patients need to come here emergently. They can become incredibly sick, as I just mentioned. However, they can also bounce back very quickly. And that's because the bleeding is outside the dura, and the brain itself is typically, I don't want to say unaffected, but less affected than, say, people that have subdural hematomas. So if you look at the, I didn't mention that, but if you look at the epidurals, because the epidural doesn't cross suture lines, because the dura is adherent to the suture lines, you get this biconvex lens shape. Now, if you have a subdural, because it's not impeded by that, the blood can track all along the hemisphere and you get this more crescent shape. But you can have different appearances. So this is a subdural that's over the tentorium. This is a subdural that's over the or is adjacent to the falx. You can have small subdurals, and you can notice that this hemisphere is shifted over, and this one too. This hemisphere is shifted over a lot more than what the size of the hematoma is, and that's indicative of worse damage in the brain. So subdurals in general don't do as good as epidurals if the epidural is caught well. And the mortality for subdurals is really dependent on the GCS, and the GCS is reflective of the neurological function of presentation. So what they're saying is if people come in with a really bad clinical exam and an acute subdural shift like I showed you, even if we take them to the OR and evacuate that, the outcomes can be quite guarded and unfortunately not very good for a lot of people. The other focal thing I'll just mention is skull fractures. These can be depressed or linear like I showed you before. Basilar skull fractures can be associated with a CSF leak or possibly with cranial neuropathies. And then lastly, for this section is the diffuse injuries, and we won't get into this a whole lot, but we do. This is a common thing that we see, and this is related to swelling of the axons and then rupture of the axons due to loss of normal conduction of intercellular machinery, and it's highlighted by retraction balls. And what you see on the MRI scan is in typical areas like the posterior aspect of the corpus callosum or in the midbrain, you see these high signal intensities that are reflective of large bundles of axons that have been disrupted. All right, so there's a concept in CNS injury that is important to mention, and that's a primary injury versus a secondary injury. And the primary injury is what happens to the neurons and axons and other supportive brain tissue when the initial trauma occurs. It's the transfer of kinetic force, it's disruption of anatomy. And the treatment for this is preventative. So as we showed before, if we have less motor vehicle crashes, we'll have less primary injury. What we focus on when it does happen is the secondary injury. And I'm not going to get into this because it's probably more than what we can cover right now, but suffice to say, there is a multitude of biomechanical cascades that occur after injury that can feed back and cause survivable tissue to go on to either apoptosis or necrosis and lead to further deterioration. This can happen in any CNS trauma, but this is the focus for the interventions that we do. And there's some guidelines out there, and I just put this up for a reference for those of you that are want to dig this up and look over it. This is not solely looking at the first hour or two or three, but really the management of the entire spectrum of care. We'll focus today's talk, as I mentioned, on the early interventions. There has been an update in 2020, but that only looked at a certain aspect of the surgical management, so I won't bring that up today. Or we can talk about it if you like. So where are some of the opportunities that we have to try to have an impact? So there's a number of different systemic causes that can contribute or exacerbate secondary injury, and those are listed there. And then there's a bunch of other stuff which I think is interesting from an experimental and lab basis, but at this point in time is not really mainstream for clinical intervention in a broad context. But this is where we can make a difference early on. So I'm going to just take a few minutes and maybe walk through a couple of things that may or may not be new to you, or maybe just presented in a slightly different way. But these are things that we can do from the time we arrive on the scene to the time we get to the definitive care and then beyond. So hypoxia. So if you define hypoxia as a single observation of the PaO2 being less than 60 millimeters, or if somebody's clearly cyanotic and apneic, that's an obvious one, or if they have O2 sats that are less than 90, then those people will present with a depressed level of consciousness. There can be a number of different reasons for that, both from a neurological standpoint, from a drug standpoint, from drugs they consume before their injury. There can also be other trauma-related reasons for the hypoxia. However, suffice to say, almost a quarter to a third of patients with a severe TBI will experience hypoxia. And this is important because there's a significant difference in mortality if you have sustained saturations less than 90. If you're not hypoxic, then all comers in severe TBI, mortality is about 14% in this particular study. But for the patients that were hypoxic, the mortality was over 50%. Now this is obviously a SAT of 60 is worse than a SAT of 90. But this has been borne out in other studies, but the pivotal study was in the Journal of Trauma and by I think it's Ron Chestnut. And we know that increasing the oxygenation can, or increasing the FiO2 can improve oxygenation. So we're told, you go into your trauma room, you want to make sure that you've got 100% oxygen and a rebreather. And this is one of the reasons why, because it makes a big difference in terms of survival. Hypotension, another one that I don't think people would find surprising, but if you have a single observation of your systolic blood pressure less than 90, your mortality goes up by 27 to 50%. And hypotension is one of the most powerful predictors of outcome in severe head injury. So it's critical that we maintain an adequate systolic blood pressure. Now the numbers have changed a little bit. This is the new threshold that came out in this particular iteration of the guidelines. But if you're in the 50 to 69 age range, you don't want to be below 100. And if you're either younger than that or older than that, you probably, or at least the data would support that you don't want to be below 110. And I'm not 100% sure that this isn't just representative of the study population and some nuances that'll be borne out later. But if you're 1 year difference, why 10 millimeters of mercury makes a difference or not may not be intuitive, but that's the recommended guidelines at this point in time. So those are the two probably most obvious things that people will look at. Other things, we want people to be have a normal glucose. If you have your glucose higher than 10 or 11 millimole, then that's been shown to have a worse prognosis in head injuries. We want your sodium to be normal. There's been many studies looking at things in different ways in terms of treating head injuries with hypothermia, and it doesn't seem to really make a difference when you pull that data together and look at it objectively. So we don't push for hypothermia. We don't want people. Sorry, we don't push for hypothermia, but we don't want people to be hyperthermic, because if you look at some of these things that are driving bad outcomes, they're the same kind of things that disrupt or increase the metabolic rate of neurons. So if we're trying to protect neurons and we're trying to get enough oxygen in with enough blood flow, and we're doing that in a tenuous fashion because of trauma. If anything else is going on that drives up the demand of those neurons for oxygen, it's going to put them in a worse situation. So that's kind of one way that we can conceptualize things. The other thing that I suspect a lot of people have heard about is increase in intracranial pressure. So we talked about this. We looked at the Monroe-Kelly doctrine. We looked at how incremental changes in volume within the closed box can be compensated until a point of decompensation. And then small changes in volume result in large changes in intracranial pressure, and large changes in intracranial pressure decrease the amount of blood that gets into the head and the blood flow. And then we can see how this cascade, this circle, continues to propagate itself. So high ICP has been fairly well established that it does lead to secondary injury through probably a number of different ways. I just talked to you and just re-described the blood flow issue. We talked and saw pictures earlier about how herniation syndromes can result from high ICP. And there can also be some cerebral edema that happens, which then again propagates a higher volume within the brain. So if you've got leaky capillaries, you got damaged brain, more fluid comes out, that further increases the space, increases the intracranial pressure, and we're feeding back on ourselves again. For quite a while, 20 millimeters of mercury was the chosen threshold. They've now recommended 22 millimeters, but those are not magic numbers. People can get sick and can have herniation syndromes or other problems at lower levels of intracranial pressure. So most people in that golden hour are not going to have a clear number to follow, but if we have a suspicion of high intracranial pressure from our examination, or if there is a CT from the appearance of a CT scan, there are some basic things that we can do. We can reduce the agitation of patients. We can reduce the metabolic demand of brain tissue through sedation and analgesia. We can help facilitate drainage of CSF and venous blood from the brain by putting the head up. And we can look at mechanical ventilation to alter the relative vasoconstriction or dilation of the arteries. And we'll touch on that in a second. So with regards to sedation, there's no great data. I mean, propofol is used commonly. I bet you everybody here has seen that, used it, or has experience with it. I think there's a couple of advantages of that, as it does also suppress EEG. So again, we're driving down the demand for oxygen by the neurons. Midazolam is another option. Opioids, people have pain, we should treat their pain because that's going to further aggravate things as well. Just be cautious with bolusing things because there may be a small or short transient increase in the ICP. We mentioned briefly about head position. We typically say 30 degrees. There's been some studies to suggest up to 45 degrees can have a noticeable impact on the intracranial pressure. So if there's no other reason, remember we're still looking at ABCs before we get to D, and there may be other reasons why people can't be head up, but if there's not, then it's a good idea to get their head up. So ventilation. So if people are not protecting their airway, and typically it's a bit of a knee-jerk thing. If your GCS is 8 or less, that you should be ventilated. And there's been questions and some change in the approach with regards to hyperventilation. What about PEEP or no PEEP? And I think that the tables have turned a little bit. The hyperventilation that we used to use years ago is gone by the wayside largely. It still may be used occasionally for very short intervals, such as the blown pupil, patient about to die, on the way to the OR for a definitive procedure. But outside of that, it's really lost favor. We don't want people to be hypercapnic, but we want them to ventilate in a low normal range. Again, it's all driving the oxygenated blood flow to the brain. So again, hyperventilation is it was recommended in the past and is no longer recommended. So normal carbia on the ventilation. And then I mentioned PEEP. So a lot of people years ago said no PEEP because they would think that would drive up the venous pressures and prevent venous drainage from the brain, but that's probably not the case. And there's been a number of studies that show that PEEP up to 5 or 10 millimeters can be safe, and it can actually be beneficial in people that get neurogenic pulmonary edema or ARDS related to their head injuries. So PEEP is okay in low levels like that. So we're starting to wind down here. I think the other thing that people will see or hear of in terms of the management of high ICP or people in extremes historically would be mannitol, and it does expand the volume, but it doesn't expand the intravascular volume, but it also improves the rheostatic flow of blood. So the idea was that more blood can get into the brain, and it's been shown also to decrease ICP. So we've used this for years and years, and I suspect many people have seen use this. There are some caveats, and you have to be cautious. You have to use a filter and watch for hypotension. You have to watch the serum osmolality, and there were some issues with it. And I know that years ago we talked with the people in Life Flight, and it would crystallize and stuff. So largely, we tend to use hypertonic saline a little bit more than the mannitol nowadays. It's not definitive. The guidelines still lean towards mannitol, and if you pool people, not quite a 50-50 split, but it's pretty comparable. Cochrane review showed there wasn't any real difference between the two, so that's what we would tend to use now, a little bit more so than mannitol. Just a quick slide, because people ask this all the time, what about steroids? The short answer is no. They've actually been shown to be detrimental, so we don't use steroids in severe TBI. So that's a little bit of not a little bit, that was quite a whirlwind tour. Certainly there's lots of gaps that were left there. Probably lots of repetition for many people. Hopefully there may be one or two nuances that people take away. But just to recap, the initial assessment, it's critical that we do our ABCs. If we don't ventilate, we don't oxygenate, we don't have good blood flow, then D doesn't matter. So those things are critical. Our neurological assessment is our Glasgow Coma score, 3 to 15. Our lateralizing signs, does one side of the body move better or more appropriately than the other side of the body? And pupils, are they equal? Are they reactive to light? Who needs a CT scan? Those posters should be up everywhere. That's what we'd recommend that people do across the province. If you have any questions, please feel free to reach out, or if there's something you're uncertain of, we're happy to take the calls. But remember that for people that need to be transferred for whatever reason, we shouldn't delay their transfer to get a test. Who needs to come to Halifax? Obviously, anybody with a severe head injury. This is the only center in the province that has neurosurgical services. But really, if there's anybody that is unsure or just wants to ask a question, you can call either the trauma team or the neurosurgery. We can do a three-way call and sort out whatever questions you may have. Just to recap the opportunities that we have to impact outcome pre-hospital. There'll be some overlap here. We want to make sure that people are oxygenated, intubation if GCS is less than 8 or they're not protecting their airway, avoiding hypoxia, we're avoiding hypotension with resuscitation, and we're trying to keep people normothermic. And we have to immobilize them for other injuries. In your local hospital, again, repetitive, ABCs are critical. We need to avoid hypotension, hypoxia, to prevent secondary injury. We can keep the head of the bed up. We do our initial assessment, and then we call for help. And I think that's about all I want to say or have to say about that. As I say, that's a very fast whirlwind tour. So I'm happy to take any questions or try to clarify anything I glossed over too quickly. I'll turn it back over to you, Bree.
All right, thank you, Sean. That was great. If anyone has any questions, now is your time. Enter them in the chat box now. But other than that, I think that was wonderful. It was very clear. Okay, it doesn't look like it.
Okay.
So I guess we'll wrap it up. It looks like there's no questions, so we'll wrap it up. Thank you again, Sean, and thank you everyone for attending.
Okay.
Thanks, Sean. That was great.
Yeah, that's good. There's no questions. All right.
Oh, I have...
anything else you need from me, Bree or Rob?
Oh, it looks like we do have a question
Oh, we do?
by Chris
There.
here. He's got his hand raised, maybe. Oh, here we go.
Who? I don't have a question.
That's okay.
On my screen.
It says, with the suggested threefold increase in MORT for hyponatremia, would you run an ISTAT prior to running 3%?
That's a good question. I think it's a balance of things. If you're using the 3%, or if you're getting to the point where you're using 3% or mannitol, you're probably in an extreme situation where one issue is trumping another. So I'd be less concerned about because these are not prolonged treatments; these are short-term treatments generally. So I think in the early stages, the first hour or two, if somebody has an acute decompensation, blows a pupil and is herniating, what their sodium is less critical in trying to lower their ICP. So for that situation, when we're using that, probably not as critical, but it's a good point.
And then another
And
question.
it looks like we have another question about the role of paralytics in pre-hospital setting in severely head injured patients.
Yeah, so I think there's probably two ways to look at this. I mean, certainly you'll hear a lot of belly aching from those that complain about not having their ability to do an exam, and that certainly is a valid point, and it's a very important thing in terms of our decision making. However, that has to be balanced with the safety of the overall situation. You have to maintain an airway, and you need to secure the airway, and you need to use paralytics to do that. If you're transporting a patient and the patient's agitated and they can't settle with just some sedation and it's a safety issue, you have to balance that. So there are two sides to that. I think that we need to do the thing that's the safest for the patient, but bearing in mind that the decisions that we make from a definitive care standpoint are heavily influenced on the exam, and that sometimes delays things. But again, you deal with things the best you can.
Okay, thanks, John. I think that's the end of the questions.
All right. Thank you. So you have to stop this, is that right, Bree, or do I have to do something?
We are good. That's the end of our webinar, so guys. So what we're going to do is we'll stop the recording and then we'll close the webinar. So thank you all for attending, and we look forward to hopefully seeing you again in January.